Pittsburgh, and I'm an associate professor there, and I'm a general cardiologist. Thank you for the introduction, Dr. Williams. As we said, I'm interviewing, and so I'd like to be considered my candidacy for a position here with your faculty. I think that the details of the training and biography were summarized. I started at Boston University in 2009 after fellowship doing general cardiology. And there I did a career development award from the AHA and a Doris Duke Clinical Scientist Development Award and something called the GemStar.
And one little thing, I'll
Sure.
get that off your screen there.
Thanks. Great, thank you.
Yeah.
Okay, which is an NIA R03 for a grant for people who are doing aging research as well. And I was working on cardiovascular disease, so it was very appropriate. I was recruited to the University of Pittsburgh in 2016, and I've been leading some research there, including a K-24, which provides support for mentoring and career development of my trainees. And just a couple of comments about my research. I know some of you aren't clinicians, but I hope that everybody finds the talk relevant today. First is my commitment to clinical research requiring a public health impact. I really feel like I appreciate research as having that relevance and that immediacy of relevance. So that is one of the pillars, I think, and motivators of my work. I also feel like more and more as a cardiologist, I really need to learn behavioral strategies, and it would be great for me to partner with a psychologist and have a psychologist with me at every clinic visit, because I think that so much of, or a behaviorist, because so much of cardiovascular disease management really is about behavioral strategies and teaching people how to avert the tolls of cardiovascular disease. And finally, I think this comes around to the notion of precision medicine and individualized therapy, or else examining disease in communities really requires that we integrate a social and structural context. Those are three commitments that I expect to maintain throughout my career. Today, we have some questions. The first is, does guideline-based care exacerbate health disparities? Hey, wait a minute, aren't we supposed to be following guideline-based care? And how can it possibly be making the problem of health disparities worse? That's a question that I think that we should ask today. The second, what are the mechanisms by which social and structural factors will contribute to adverse outcomes? Why is that the fact? And finally, let's get to some solutions. What can we do about it in our practice and in our clinics, in our health system, and in our society as well? These are the questions that will frame our talk today. So this is a figure which is from the American Medical Association, which I think summarizes the impact of social and structural determinants on health. The conclusion here is that only 20% of health is attributable to healthcare. And I guess the authors of this figure, they put that healthcare at the feet and not in the head. Basically, maybe that's to show the importance of thinking about socioeconomic behaviors foremost and trying to find ways to address them, the physical environment, and also health behaviors. I shared this with my cardiovascular interventional colleagues back home in Pittsburgh, and I say to them, wait a minute, I love you guys, but think about this. All this attention that we're giving is very reactive towards cardiovascular disease. We're providing procedures and interventions, a whole host of technological solutions, but we're not addressing the upstream factors, the socioeconomic and the physical and the health behaviors that are just so fundamental and critical. And I think that's really summarized very much by this figure here, published a few years ago, which examines income and life expectancy in the United States. And this is a chart that looks at the relation of household income percentile from 1% to 100%, tracked by tax returns, and expected longevity of people at 40 years of life. And this is combining data between IRS data on looking at tax returns and also the National Death Index as well. And it's not at all subtle what the trajectory is. And what always surprises me when I see this figure is that it's not 2 years difference or 5 years difference. it really is colossal between the top 100% and the bottom 1%. And it shows, I think, just the tremendous deficit of addressing health equity in our society and in our healthcare system. So in a way, it begs questions here about how we can possibly promote longevity in people who have structural obstacles to care as well. And I think that we can see some mechanisms by looking at this concept of structural disparities in people who are underinsured or not insured. And these are survey data that are representative of the United States, people who are 18 to 64 years old, so they're not Medicare recipients. Looking at people who are underinsured, defined by having to pay 10% or more of their household income for their healthcare, or else those who are 200% of the federal poverty line, 5% or more. And what this histogram shows really is that there's profound deficits in terms of people having problems with regard to accessing healthcare based upon being underinsured and having these out-of-pocket costs. And if we look at actual chronic diseases, from asthma, pulmonary disease, diabetes, heart failure, and then hypertension, high cholesterol, we can see that people who are underinsured are foregoing care in these areas. So 20% of my patients who are underinsured are foregoing care. They're not coming to visits. They're not picking up their medications because they can't afford the co-payments, or else they have other obstacles to their care as well. And so I have some action items here throughout the talk, and one of them is just to ask patients when we see them about the adequacy of their insurance to cover their medical costs. Shouldn't we know if our patients are underinsured? Shouldn't we know how much they have to shell out every month when they go to pick up the medications that we prescribe? So here's some research that I did, and this is data from an administrative data set called Optum Clinformatics, which is a comprehensive claims-based system of about 65 million lives. And what we looked at was in individuals who've had an acute coronary syndrome and are placed on appropriate medication following the PCI, that is, they're given antiplatelet agents, guideline-directed therapies, what is the association of their household income with the likelihood of them having a 12-month adherence in this administrative data set to this medication? And here, income is determined by Optum using a commercial firm, which looks at the zip code +4, a very precise geographic measure, as well as survey data and consumer data. So I really trust it. However, in Optum, in the data set, the social view, it's only categorized here, as you can see, across these strata from less than 40,000 a year to greater than 100,000 a year. It's not more granular than that. Adherence is measured by using pharmacy claims. And so we can look at administrative data and we can see when did people actually pick up their medications. And what we can see in the kernel density plot, as well as the odds ratios, is that there is a marked gradient between these estimates of household income and the likelihood of adherence over 12 months. And this is troubling. 50% of people who are at the lower end of household income are not adherent relative to those who are at the higher end of household income. This work was done by one of my mentees, Anna LaRosa, when she was a general cardiology fellow. She's now doing an interventional fellowship at Mass General. We had presented that also at an AHA meeting. And I want to move now to Entresto, sacubitril valsartan, this medication that we use so prominently in heart failure therapies. So there's a couple of cardiologists in the room. How many people here have prescribed Entresto to their patients? Probably many of us have, and it's a medication that I prescribe every day. So this is, again, claims-based data. This was done by my mentee, Amber Johnson, who had a diversity supplement in one of my R grants, and now is an assistant professor at the University of Chicago with a K-23 there, in which I'm primary mentor. And she examined whether or not household income was related to just having a claim within 6 months of a diagnosis of heart failure in the Optum data set. Stunning as well, right? The fact on your left that people who are earning less than 40K are so unlikely to have a claim for Entresto. And then on the right, looking at adherence at 12 months in this data set as well, the very same finding too. This is actually really troubling. I have just a patient of mine I saw last week, and he is a retired school teacher. He gave his life to education in the public schools, and he has a cardiomyopathy, and I'm treating him. And we just determined that he will no longer take the Entresto because he cannot afford the $500 copayment. Meanwhile, every week or so, I seem to get this publication in my inbox from one of the esteemed journals, which is really pounding on us, saying that GDMT, guideline-directed medical therapy, we need to be aggressive with our patients. We need to prescribe them this quartet of medications that include Entresto. And this is in contrast because this is the reality of what patients experience. And so what is, just very briefly, what is Entresto and the GDMT regimen? What does it actually cost? Well, these are data from Medicare, which are analyzed here by monthly, the list price being about $1,300 actually, and by the list price. And then what people have to pay who have Medicare Part D with or without from their own spending, with or without coinsurance. And so this is a figure. So this is not my research at all, but I think it's very informative, which shows the fact that people with Medicare, they first pay a deductible, then they have initial coverage, they go into what's called the coverage gap, and then currently they paid about $7,400 out of pocket for their costs. They have what Medicare calls catastrophic coverage. And so this is about as wonky as I get. I think what it shows here is that the Inflation Reduction Act, which is the Biden, I think, one of its signature accomplishments, it's going to reduce this payment considerably. But it actually means that out-of-pocket costs for medications will still be about $4,000 per year, which is prohibitive for many seniors in terms of getting these expensive medications. What we know is that about 10 to 15% of our patients who are prescribed these expensive cardiovascular diseases, these pharmacologic therapies for cardiovascular disease, are not able to afford and have very high out-of-pocket costs. So this is the last slide with regard to Optum and the analyses that we did. And this was done with my friend and mentee, M.Sc, in which we looked at the glucagon-like peptide receptor agonists, the GLPs, which are now very in vogue. We know that they're extremely important medications. And we looked at the association of copayment. How much do I pay when I pick up the medication? And we described the copayment as being low, $10 or less, medium, up to $50, and then high, greater than $50. And we looked at whether or not people were adherents at 12 months to these medication therapies, again, using pharmacy claims data in this database. We did the same thing with the SGLT2 inhibitors, and both results are very similar, which is that people who have the low copayments are able to stay on the medication, and those who have the medium and high copayments are markedly less likely, significantly so, to adhere to the medications at 12 months. So we have a great armamentarium if you can afford it. And if you can't, then we have very limited means to provide you with the GDMT that we espouse. So I think our second action item for today is to quantify the magnitude of the copayment that patients have. And this is something that we can just ask people. So when I prescribe these therapies, I tell them, let's look up how much it's going to cost you. If we don't have that information, then I call them or my nurse calls them to find out whether or not they were able to access the medication because of the copayment cost. I want to transition and talk a little bit about education, because I think education as a social determinant, it occurs early in life, and it has such important contributions to how people live and the remainder of their lives. And so I was fortunate to do this analysis with the group at Northwestern that coordinates the Lifetime Risk Pooling Project. This is the same collection of cohort-based studies that were used to develop the pooled cohort equations, and the LRRP has been used for multiple analyses. And what we did that I think distinguishes this analysis of the relation of education and educational attainment to cardiovascular outcomes is we were able to pool together 6 different cohorts that included Eric, Framingham, Mesa, and others, Cardia, and we were able to look long-term at decades following people's educational experience. And we're able to see the effect of education on the lifetime risk of cardiovascular disease, and to see that it's sustained not in the short term, but throughout their middle years and also older adulthood. So I think that it's a very simple question to ask people what their educational attainment was. And it can help us understand a lot about health literacy, which I'm going to speak about in a moment, but also about their lifetime cardiovascular risk. And so we applied the same principle and we looked at the SPRINT trial. Are there people here who are familiar with the SPRINT trial? This was a definitive trial for blood pressure treatment. Clinicians know what it is because we see it referenced so much, but it defined the guidelines and the way that we treat hypertension. And it defined an orientation towards hypertension to really overcome that clinical inertia and be sure to intensify patients' blood pressure treatment. And so what we looked at in this study, which found that intensive treatment is so superior to laissez-faire, right? To just let the inertia run and not modify it. Intensive treatment was able to reduce the composite outcome of cardiovascular diseases. And so my mentee, Josh Garfing, who is an MD PhD student in our School of Public Health in our medical school, he stratified by educational attainment in this cohort in SPRINT. Actually, this was the only social measurement that we could see was collected in SPRINT. And so what he saw here was that people who are given standard treatment, regardless of education, their blood pressure maintained across the 5 years of the study. Those who receive the intensive treatment, you can see here, definitely effective, right? It doesn't matter what your education is. And this is very similar to the New England Journal paper, which showed that intensive treatment lowers blood pressure. That curve on the bottom here looks just the same as what we have here, stratified by educational attainment. And so my hypothesis was, well, I think that we're going to demonstrate that people who have lower education, they have a greater benefit. They have a more robust benefit with us intensifying their blood pressure control. We're going to do better for them. That was what I hypothesized. And was I wrong? Was I right? I was wrong. What you can see here is actually, I think, pretty concerning to me, which is that when you look at those who had only some college and those who had less than college, it didn't make a difference whether or not they were randomized to intensive treatment or standard treatment with regard to the cardiovascular outcome. That is to say that it definitely decreased the likelihood of cardiovascular events in those who had greater than a college degree. You can see by 50%. That was really a very successful intervention for them. But it wasn't for those who had this lower educational attainment. And I think that this really stands the trial on its head, because what it tells us is that despite the intensive blood pressure lowering that occurred, there was no difference with regard to the outcome. To me, that's very humbling, extremely so, because it tells me that no matter what the armamentarium is of pharmacotherapies that I could provide the patient, that's not enough. That is not adequate in order to decrease the risk. And so this is now under review, and I think it's going to be in JAHA probably in a couple months. So I really want to point out that if we don't collect these data in our clinical trials, we won't be able to do this kind of subgroup analysis. And I've had interactions with the leaders of clinical trials, asking them how we can incorporate these measures because of their value in performing these types of subgroup analyses and understanding the generalizability of what their findings are. And if they're not collected, we won't be able to do this type of sensitivity analysis. I want to go back to health literacy because I was the lead author of the AHA statement on health literacy and cardiovascular disease, and just the real importance of literacy in terms of being a cardiologist and making sure that my patients understand what the instructions are and that they can participate as partners and that they can take agency. And health literacy is a very critical ingredient to that. It's associated with a lot of behaviors, particularly adherence, self-care and management, and has been associated with a range of hard health outcomes like hypertension and hemoglobin A1C, as well as poorer health status and increased healthcare utilization. And so Healthy People 2030 really prioritized health literacy in a way by looking at not just personal health literacy, but organizational health literacy. And so as an organization, are we committed as healthcare providers to equitably enable health-related decisions? And what I've done is I've put some of my patient instructions at my medical center through a readability index to assess their readability, to find out that our materials are in excess of college, basically. It's an easy thing that you can do using something called the Flesch Kincaid, and then you can assess readability by grade level. My studies, I use a readability measure to assess the readability of my informed consents. And so they're written for a 6th grade level, send them to the IRB, they come back with all the standard IRB language, and now they're 13th grade. And so I've had a lot of discussions with the IRB about all the legalese and terminology that's introduced to an informed consent that patients cannot understand. Finally, they let me put a box around it. So that way, when we do informed consent, we could say, this is material in the box, and we're going to now help you to understand it and summarize it for you. And I think our participants appreciate that. And we assess health literacy in our studies using something called the newest vital sign, which is this cool instrument, which is now owned by Pfizer, but is publicly available. Just look it up, the newest vital sign. It looks like an ice cream nutrition label, and you ask people some questions off of it, and it takes 6 minutes. And so I've actually, as a co-investigator, have prompted the introduction of this measure to multiple clinical trials that are being done in order to be able to examine the effect, the modification of the result by health literacy status. Otherwise, there's this 3-item screener here too, which people tend to use. And so this is just a quick example of work that's been done in the field of health literacy and heart transplant centers. I really blew the cardiovascular surgeons away when I told them about this, and then they got very interested because this simply showed that in patient-facing material, much of our literature is very much in excess of what we would expect in terms of our median patient education. And this is work that I was able to do, again, with a mentee, in which we looked at about 300 people who are receiving care at our institution, and we just asked them to estimate their annual risk of stroke if they had the chronic cardiovascular condition called atrial fibrillation, which is associated with stroke. And we clinicians, we use that assessment of the risk of stroke in order to determine whether or not they should receive a therapy called anticoagulation, which reduces the risk of stroke. So it's a really important determination. And part of the shared decision-making espoused by the guidelines is that patients have an understanding of the rationale for this medication. And so we asked them to just estimate their own risk of stroke. And then we compared that to our risk of stroke based upon the instrument that we use. And what we found was, wow, was there such an incredible difference in terms of how patients estimated their own stroke risk. And I thought this was very informative. These are patients who were treated by my colleagues in cardiology. So I showed this to them. And then I put their AFib center patient literature through the readability index and found out that it's for grade 17. So they were, they learned that as well. So I think we can assess the readability pretty quickly of the materials that we provide to our patients. I guess thinking about social risk, there's a lot of emphasis on social risk in the life course perspective and the experience that people have. And I think this is a pretty good model, which shows how from birth through older age, there's different factors that will inform whether or not people have the risk to their health and their health in general. But I think that what's really missing from this is a very prominent characteristic that defines our health and our health opportunities, and that is our neighborhood context. And so that is definitely a deficit in this work here. And as somebody who uses a socio-ecological model or framework, I think that we have to think about the context in which people live. And so one way of doing that is looking at the area deprivation index, which I have here for the state of Pennsylvania and the state of Kentucky. Are people familiar with area deprivation index? It's something that you can download for an individual address for your study so that you can tag people with their area deprivation. And this, as an index, measures from 1 to 10 in the state and from 1 to 100 in the country, with higher numbers indicating more severe deprivation. This is published by the University of Wisconsin, and my residency colleague, Amy Kind, leads that. And it's accessible. Of course, the use of it is that it is a summary of 17 different census measures that are constellated in order to just develop this index here. And so red indicates that people have greater deprivation, and blue obviously less or so. And so you can see that both of our states look very heterogeneous in terms of the census tract and the level of deprivation at the census tract that's experienced there. And this is Kentucky, and then now we also have Louisville here, and you can see that there's really a nice divide in your, Dr. Williams, I'm going to send you the slides.
Oh, I want the picture with you in it.
Okay, okay. So really, I think this is pretty important as far as understanding Louisville, and there's been a lot of attention to the social challenges in Louisville. You can see that across census tracts, the color doesn't even blend. It's like there's almost a border there. And so you're addressing this. I in preparation for the visit, I read the 2017 study about the disparities of longevity across the communities of Louisville. And I also looked at the university's project for Louisville 2040, which aims to address the social disparities and to make greater parity in your region and in your city. So I guess, head west and you head into the red, and head east and you're going to go into the blue here. And this is not by accident, actually, right? We have heavily segregated cities, and we have cities that have a legacy to them in terms of redlining, as well as the historical legacy of people who lived in slavery, and people who experienced the segregation that resulted from the Baltimore Ordinance of 1910, and the way that also informed segregation of our cities. So I think this is an important measure to consider. And if you can't do GIS and look at census level measures by address, then you can use, for the census tract, you can use ADI. And we could also use this, I'm going to talk later about hotspotting. And so we looked at those people who had used our medical center, and we looked at the association of area deprivation index with recurrent cardiovascular outcomes and readmission. And we found here that there was indeed a gradient, particularly with the in area deprivation index. If you look at B, myocardial ischemia and heart failure, there's really a splaying of those curves over time. People with higher deprivation are much more likely to suffer recurrent heart failure and recurrent myocardial ischemia. And with one of my mentees who's a medical student, we looked at the likelihood of receiving oral anticoagulation in 90 days within a diagnosis of the heart condition atrial fibrillation. Again, a condition that is places people very much at risk of stroke. And so we think about giving them the oral anticoagulant. And so we looked at whether or not people were prescribed any oral anticoagulant, or whether or not they got a superior agent, which is called a direct acting oral anticoagulant. You might have, it's heavily advertised, something like Eliquis, right? You might have seen the TV commercials for it. And in this case, what we found was that there was markedly lower likelihood of receiving an oral anticoagulant or receiving the DOAC, the superior agent, at 90 days in those who were in the second, third, and fourth quartile of area deprivation index. And so this is what's going on in our healthcare center, which is that there's an undertreatment by area deprivation index. And that's a profound problem, I think, to address. We also, Pittsburgh has a whole industrial legacy to it. The steel mills that used to be there, there are still coke factories, and there's a lot of particulate matter, an excessive amount of pollution. It's still known as one of the dirtiest cities in the country to live. And so Zach Reinhart when he was in fellowship, he's now an attending with me. He examined whether or not the particulate matter 2.5 plus in combination some census measures, whether or not that was associated with increased risk of stroke. And what he found is that those who had the highest level of particulate matter, that's the first quartile, were much more likely to have stroke compared to those who had the lower quartiles of particulate matter. So again, there is a gradient that you can see there where the gray dotted line on the bottom is very much distinguished from the others. And these are people who had the highest exposure to particulate matter. So showing this as an example of my work and also as an example of the opportunity to combine data from an electronic health record to look at care. And this could also be used for quality improvement. This could also be used to partner with community members in order to engage in interventions and to spotlight the way in which industrial factors and census level factors contribute towards health outcomes. And we were just talking recently about this notion of the zip code, and there's this kind of assertion. You've heard people say the zip code is more informative than people's genetic code, and I would say actually, well, we can pick at that a little bit because zip codes are pretty large and they change, and they're for mail delivery. They're developed by the postal system, so they're not fixed, and they can even cross counties basically. But if the zip code is not more informative, it's what your neighborhood is. It's the blocks around you in terms of where you live. And so this is life expectancy in Pittsburgh, and these are recent data. And there is obviously tremendous difference here. In fact, this looks very much like the first figure that I showed you in terms of the association of income with life expectancy. And sure enough, these numbers will, these neighborhoods will cluster according to their social demographics. I live somewhere way up to the right with the higher life expectancy in my mostly prominently white upper class neighborhood, professionals. I have lots of doctors, including my chair, who lives around the block from me. So we all live together in our neighborhood called Squirrel Hill. And I started a clinic, and my hospital where I work is all the way down towards the left, really one of the leftmost bars there. Started a clinic in a family medicine practice in order to embed myself in what's patients' homes so that they don't need to travel to another site and they can see a cardiologist on site. And that's been a really effective intervention. And I've been able to see a lot of people and do primordial prevention and primary prevention of cardiovascular disease in that manner. And that's people who wouldn't travel to other parts of the city. This is where they get their care. So zip code is not more informative. It's the blocks around us. That's going to be much more informative in terms of this really important health outcome of life expectancy. And here, when I was doing my preparation here, I came across this. It's from the National Community Reinvestment Coalition, and you could look it up. And I think this is great. This shows the, so I did no work. I just took a screenshot of this. So this shows historical redlining in Louisville in relation to social vulnerability score, which is a CDC code. And you can see, again, it's really the same story that those neighborhoods which had been red have remained red in terms of their social vulnerability. I think this is important for interventions, important for hotspotting, important for a coalition that involves municipal partners and community-based partners and us in the healthcare system, because we have an opportunity to very much partner up with these segments of a town that have this kind of historical disadvantage. And this is where we can make a difference. Certainly, looking at that figure of the Pittsburgh neighborhoods and where longevity is, I really feel like I'm right where I need to be, because I need to be in a place where the disparities, the historical legacies of disparities are just so prominent. But inequity is really a long view as well. We have to think about this in terms of the racial segregation and social factors and how they've been promoted. And I showed you that figure that showed across life stages the association of opportunities from birth to older age with health. And if you think about the legacy that carries on, that's prenatal for generations, that's kind of baked into our society. And this is demonstrated by the disparity between in white households and Black households in our country in terms of median wealth and average wealth as well, just going back for decades and decades. And so really what we have here is a historical problem. And so I read a lot of papers as as an editor and as a reviewer, in which people look at racial differences and disparities. And a lot of what I've talked about today, this legacy, is not incorporated and not addressed. So if you're interested, I really would like to refer you to the American Heart Association's presidential statement, presidential advisory on structural racism and its contribution to cardiovascular health. And what I really appreciated about it was how the authors traced back racial disparities all the way to slavery, reminding us that this is just centuries of inequity that have become a part of our society. And so interventions have to be very complex. Structural problems need structural solutions. And so one of the take-home points here for us is also that race is a social rather than a biological construct and has to be treated as such in our analyses, particularly incorporating the legacy of disadvantage that I've highlighted. But if we think that we can just correct this with education or with something simple, this is another analysis that we did. This is using NHANES data. And essentially what we compared was whether or not there was cardiovascular health obtained by education. And we could see that in those who are non-Hispanic white, there is tremendously increased likelihood of people achieving ideal cardiovascular health using NHANES by achieving more education. But actually, in those who are non-Hispanic Black and those who are Hispanic, the difference is present, but not nearly as significant, not nearly as prominent. And this is, again, to remind us that structural problems need structural solutions. Speaking of solutions, okay, a little shift here. Now we should talk about what we can do, right? Instead of just laying on the crepe, we should think about together what kind of things we can do in order to address this. And I'm gonna highlight in the healthcare system and in society and in our delivery of care. And the first thing I think we can do is when we next go into the exam room and see our patients. I have lovely colleagues and they say, well, you want me to ask my patients about social factors? And I say, well, if they're not going to be able to afford their medications, they're not going to be able to pick up the medications, they're not going to be able to take them properly, they won't adhere to them. Don't you want to know that before you prescribe? And so it really doesn't take a lot of time, and it doesn't take a profound relationship with people to ask them about themselves. And so when I meet my patients, I want to know what they do, who they live with, what their environment is, and I want to understand what their education is. I want to know if they can read, and I'd like to know where they live, because all of this will be very important. Remember the 20/80 rule to ascertaining their health and the factors that will contribute towards their health. So I think that these are just a couple of questions that the CDC publishes, the social determinants of health. If we want to address social determinants, we can just start today. It's not that hard. And then we can incorporate this into care. And one of the problems, though, is that it's not really in the medical record. And there's no place really to record it. And so if I assess it, then I can put it in a note, but somebody might not read that note, that this patient has a fourth grade education, for instance. And so the National Academy really made this pronouncement that we should integrate social risk into clinical care. Great idea, but what you can see on the bottom here is it's in a couple of studies. It just hasn't been successful. It doesn't show up. And this is from one of my patients. This is his profile here. In the interest of time, I won't read all these, but basically what it shows is that he has a constellation of social risk factors that I know because I asked him and he told me. And, I look at my EPIC social determinants of health dashboard, and all we learn here is that he smokes. Nothing's reported. And so if it's not there, it can't be utilized and it can't be integrated into the way that we practice and the way that we treat this patient. And so that's a problem. So what I've done in my NIH funded research is to try to set up the trials that I would like us to do, which is to collect social measures and then to launch interventions that can address them. And so I want to talk about those studies that were designed for people particularly people who had low literacy. And one of them is using an intervention to address adherence to, again, oral anticoagulation, which is so important for stroke prevention. And so I did 2 studies, randomized clinical trials, with the outcome being adherence and a couple of secondary outcomes to try to intervene in patients who may have some social challenges. We used something called a relational agent. This was really cool. It was introduced to me by a colleague in Boston. He had validated it for older adults, particularly those who had limited health literacy. And it's a longitudinal coach people could interact with on a smartphone. People might call it an avatar. It's not like a chatbot at all. It's written and programmed so that people can have sophisticated conversations with this agent. And we developed it as a smartphone app and gave people smartphones so that owning a smartphone or operating a smartphone prior wouldn't be an obstacle to participation in this study. And he wanted the agent to, he said, to look like his aunt or his grandmother when they were younger, and to be a trusted individual, not really a medical person, although she looks a little bit like a nurse. And so we partnered that with the AliveCore so that the agent can ask people to take their heart rate and rhythm with the AliveCore. We didn't get as sophisticated as we would have liked to have the agent then take in the results and respond to it. That interface was lacking in this study, but we wanted to couple it with understanding more about atrial fibrillation as a chronic disease and chronic disease self-management, which enabled us when people had symptoms, they could get prompted to use this, and then they could feel more empowered. And the control was just WebMD. And we did this study in rural Western Pennsylvania and also locally in Pittsburgh. And so we made 2 different agents here. And what I just want to fill you in on is that the agent had a lot of educational content that was very patient facing. This was like a wise person who wasn't as bossy as a doctor and wasn't as informed as a nurse, who could provide you with guidance about how to live with a chronic disease and how you could identify obstacles to adherence, which all of us experience when we have medications and we're on medications every day, and strategies for addressing adherence, how to become your own advocate in medical visits, how to use social resources, how to prepare for the medical encounter, and then again, addressing symptoms. And the agent speaks in simple language. It uses facial expressions like I am. Empathy is an important part of what we've developed. The agent looks around just like we do in natural conversation. This is actually a whole field of human-computer interaction, people using agents and studying how we can develop them as tools to help people with their healthcare and have better success. And the empathetic tone used by the agent in the speech is also really an important part of this. And so my program developed this. We implemented it in 2 different studies. We used smartphones that we sent out to people, and we had a really good infrastructure in terms of getting the smartphones back by incentivizing a participant payment for return of the phone. Phones were used a median of 3.3 times, which I think is just awesome, with them being used from 1 to 5 times each. So a real success in terms of developing a mobile health strategy that could be implemented and set up and run as a clinical trial throughout Western PA as well as the Pittsburgh area. We also provided people with a lot of instructions about how to use their smartphone. We gave them a tutorial, and then we gave them literature that was written at a level that was appropriate for older adults and people who hadn't yet used this kind of technology before, again, in order to reduce the barrier. And qualitatively, I think a lot of people appreciated having this information and having even just this training in terms of the smartphone usage. And so this is a map here of the rural and the urban participants, and these are our demographics. We were able to exceed our target enrollment in both of these studies. We emphasized recruitment of women because most clinical trials of atrial fibrillation are about 30% women. Rural Pennsylvania is pretty racially homogeneous, so we only had 5% people who are non-white. We did much better in Pittsburgh We again targeted people who had limited education as well for this trial. We were successful for that. And these are people who otherwise rarely have opportunities to participate in clinical research. And we got some great feedback in terms of qualitative analyses from our participants. They had great things to say about the agent. They really liked the agent. And this is kind of the take-home slide in terms of adherence over the course of the baseline of the 12-month visit. People who got the intervention, they had superior self-reported adherence than those who were randomized to the control condition. So we had some success with regard to that. And so we've parlayed that into another application, which I think is a little more sophisticated, to address hypertension. And we're recruiting people in rural Pennsylvania, as defined by the census definition of rural, according to their county. About 48 of Pennsylvania's 67 counties are defined as rural. And they're getting an agent in this study, and they're getting a blood pressure cuff, and the agent guides them through hypertension education and provides them with this menu here as far as how to take their blood pressure at home, and they take their blood pressure according to with the agent about 4 times a week, twice in the morning and twice in the evening every week to get an average of blood pressure. It's charted for them, and people really like being able to see what's going on with their blood pressure and watch the improvement over time with their measurement. And these results go back to the electronic health record, and the clinician is informed. And that way, actionable data, which is home blood pressure monitoring, can go back to the primary care and family medicine clinician, and then they can adjust medications accordingly or not. So our next iterations will have a pharmacist on board who will guide the intensification of therapy as well, so that we can overcome that inertia in terms of prescribing. These are, again, some materials that we provide to our patients because we're really interested in making sure that people feel like they're partnering with us by participating in the study, and they get materials that are shown here that, again, are written really at a 6th grade level. And there are some problems with this because this is funded by the NIH. It's finite. Scalability and sustainability of a smartphone-based intervention, particularly distributing phones, we found. We're going to start to let people use their own phones. Integration with healthcare delivery in real time, I think, is definitely a prominent obstacle to work on. The development of these agents has been resource intensive. And there's also bang for the buck. Think about all the directs that my team gets, right, to develop this and to send out phones, et cetera. And in this study, we only want about 330 people. Well, take that sum and divide it by 330. And imagine then if we could have individual coaches, if we could hire community health workers who could interface with people. I think as far as bang for the buck, that might be a more successful strategy than developing a smartphone-based agent. I think that we really come into emphasizing health equity from professional societies as well. And these pledges and the impact goal from the ACC as well as the AHA. And some people argue, do these make a difference? Are these just figurative or so? I think it doesn't hurt anybody at all. And I think that having these prominently at our meetings, it's a reminder to people that this is an issue that they have to be aware of. So just in the interest of time, I'll skip through that. I think that one of the things that I emphasized is, when do we collect these values? When do we collect these measures? And if we don't collect them in our studies, then we're not able to assess their importance. We're not able to include them. Most of the time, they're just dichotomized, basically social measures, or they're categorical variables like the Optum data that I showed you. But they're far more complex because we showed you education and income, but maybe education and income in terms of their prominence with regard to health outcomes vary also depending upon your neighborhood and where you live. So I think that we need to think longitudinally as well in our assessments and analyses. I emphasized understanding my patients' co-payments, because this is a financial burden to care. And people who have chronic conditions and have comorbid conditions that require multiple medications are penalized. Many patients cannot afford copays. And this is a study that was done several years ago in which people received full prescription coverage, and they did better in terms of having whether or not they had an event following a heart attack. So if we could provide people with more medications, we might see more success. Value-based insurance design is another model, another strategy that could reduce costs for evidence-based services and improve adherence while rewarding high-value care. And that's something at the healthcare system that I think we could integrate. This is an interesting study that came out this summer. It was people in Chelsea, Massachusetts, where I had my primary care clinic as a resident, received $400 a month in payment. And the take home is that there was no effect on whether or not they got their COVID vaccination or their blood pressure or any other health metrics. Receiving money didn't help them. It's curious. Another solution is hotspotting, like I said, and we could prioritize communities that have the most deficit and have the most social challenges. And you planted trees across the city, particularly targeting the communities that can most benefit from this. And this is an example of a project from Wayne Health, which uses a mobile van. And the mobile van it's not tourism. It's going to a community and setting up shop. You don't come in and drive away. You can set up an alliance and you can set up a program whereby you can come in and you can deliver services. And Dr. Williams was talking yesterday about being at a church and doing screening. And so we can hotspot communities or places where we could have the most benefit. And that's bang for the buck. So we could go to Smoketown and we could set up our operation there. And these could be multidisciplinary with community health workers and pharmacists and psychologists, because again, I emphasize that one of us as physicians or as a social worker, we're really not enough. We have to all work together. And so, and that's the kind of Swiss Army knife analogy here, which is what we need to solve the social problems that we're addressing. There's a lot of attention now to CMS in terms of the collection of social drivers of health, and we're now obligated to collect on patient admission social drivers of health. We can definitely continue with that and integrate that. We can have prescriptions for wellness that are more multidisciplinary, like I'm emphasizing here. I think that knowing patients at the time of prescription, what their benefits are going to be, having that automated would be a huge benefit to my patients, because I would be able to tell them right then what they're going to end up having to pay from their wallet when they go to pick up their prescriptions. That information should not be opaque. That should not be behind a firewall. We should be able to do that at the time of prescription, and that should be incorporated into shared decision-making to help people like the school teacher I talked about decide whether or not Entresto is going to be reasonable for him. And so the hospital inpatient quality reporting system has emphasized, again, that we start collecting social determinants, and this has shown some improvement in terms of whether it has reduced emergency room visits and avoided emergency room visits. It's actually not that hard to do. It's a standardized questionnaire. I think this is going to be more and more prominent in terms of something that we're going to be required to do by CMS. And the next stage is in 2026, we'll be asking, what are we going to do about it when we identify that people have health-related social needs? And so we can screen for health-related social needs and have a response. Let me summarize. Social and structural factors perpetuate disparities. I emphasize that. The exposure is lifelong, it's longitudinal, it's progressive. These are definitely compounded because they're related to each other. And I think that cardiovascular disease treatment that ignores this reality can exacerbate disparities. The routine healthcare system that we practice in can also participate in exacerbating disparities. We know that these measures are not captured in our electronic health record. We have limited training ourselves for what to do. And one-off solutions, maybe even those funded by the NIH, they lack sustainability, and they might not address the neighborhood and other contextual factors that drive disparities. I emphasize that structural factors need structural solutions. We need to work with neighborhoods as well, and healthcare systems can adopt universal approaches in order to conduct a kind of a harm reduction response to disparities. Thank you so much for hosting me. I'm really pleased to visit you here in Louisville. Thank you.
Really fantastic, open for questions, and I've got so many of them, and I just don't, but we'll try to go around the room before I do too many
Thank
of them.
Thank you for coming, those of you who are here.
Really amazing. So one of the first questions from the beginning of the talk is when you show the life expectancy change that happens with education, and you showed it with income. The question is, are they independent? Because education gets you income.
Yeah.
And if so, which one is more powerful?
I think that's such a fantastic question because they're very highly correlated, right? Education is a gateway towards social access and towards employment. And in our paper with the LRRP, in which we looked at education and lifetime risk, we pointed out that the cohorts, they lack ascertainment of income as well. They lack ascertainment of parental income as well too. And so that's a challenge. That's a limitation of that particular analysis.
Yeah, absolutely.
Thank you.
Right.
Yeah.
So there's a lot of great stuff in here, and I'm curious from your perspective, what do you think is the biggest bang for, like, if somebody comes into the office, you have a visit with them. While I would love my EMR to help me tell me how much meds are going to cost, I'd love it to help identify what the social determinants of health are. I'd love it then to provide patient information that's at a great appropriate level.
Mm-hmm.
Right now, that seems like a lot to ask. Is there something that seems most effective as far as outcomes and gives you that biggest bang for the effort?
And it's a lot to ask in terms of a 20-minute visit.
Well, that's what I mean. I'm thinking about, like, how can we be the most effective we can be?
Yes.
And how can we build a system that helps us get there?
Right. And I really appreciate this question, which is, what is a priority going to be? And I think what I really like about the family medicine clinic in which I am embedded is that the doctors don't ask those questions. There are social workers who are on site. There's a community health worker on site. And I'm not a social worker. I'm not a community health worker. And having a partner, a collaborator, it's not up to us. I think that it's a mistake to presume that the healthcare system is going to be able to address social determinants. We're really downstream and we're seeing the burden of it. What we can do is we can testify and we can organize our practices so that we can accommodate for that by practicing in an organization that embraces health literacy. What can you do, I think, is know your patients and simply to appreciate what are the burdens. A lot of times I find that if we don't ask people, are they taking their medications? What are the barriers to taking their medications? We leave an incredible amount, I think, unsaid, and we make the assumption that people are able to adhere to the therapies that we are prescribing. Thanks.
Nice.
This is a comment more than anything. I work in general internal medicine and primary care, and I run our resident clinic, which traditionally has a really underserved and very chronically ill population of patients. Social determinants, at work right there. I think it was a comment more on how helpful the SDOH wheel can be for physicians, because I think there's been, as primary care providers, we have a little bit of hesitation in asking all these questions when we don't have an embedded social worker and community health worker in our clinic. So you ask these questions, but then what am I doing to support the patient after the fact? But I think what was really great here is, even if you can just alert the physician, something's better than nothing there. And if you do have a physician who's not getting that far in their visit to say, are you taking your meds? What are your barriers? Oh, you have transportation barriers, and that's flagged on here. I feel like using the EMR in that way is so good. So this was just really supportive of that.
Thank you.
Even if we don't have every ideal mechanism to kind of like support the patient, which hopefully we'll get, down the line.
Yeah, well, I'm grateful that you came, and I'm grateful for your comment as well. I think that one avenue also that we can incorporate is that this is not a one-off. This is something that should be segregated to, oh, that's the psychosocial part of what we learn in residency or what we do as part of our practice, but actually something that's reinforced throughout training and incorporated. And that way, all of our trainees learn how to do this assessment. They learn this literature, just like they learn more specialized literature. If they're doing nuclear cardiology or they're in the cath lab, they should also learn about the social barriers to their patient's care, particularly practicing in a place like this. Now, as far as what the response is, the sort of, I think the kind of gold standard is that we don't assess social needs without having a solution.
Yes,
Right, like-
yes, that's why it feels bad to,
Totally.
especially primary care provider,
Yeah.
where we're trying to provide a holistic approach to their healthcare, right, you know?
Yeah, yeah. So, so people are addressing this, and creating dashboards and finding avenues whereby we who are clinicians, we get this information, or we have a social worker who can do the assessments, or not even a social worker, a medical assistant who can do these assessments. And then this gets communicated to a dashboard, and that informs a community agency, a partnership. But that requires investment, and that requires structure, and that's not simple. And so in my studies, we're really careful about the amount of social questions that we ask people, because, you know, if you can't do anything about it, aside from give people phone numbers and give them brochures for things that they can do to take care of themselves, or refer them to a social worker, then you're not doing due diligence, I think. Thank you so much.
So I know
Yeah.
we're out of time, but I do, out of the 4 questions I was gonna ask you, I'll skip to the 4th one, because it was really what Dr. Doster was asking. Why can't we just partner with Epic and have it pull the data so that we have right in front of us when we write a prescription, get the information about that particular patient's insurance and co-pays. It's a real sensitive issue because we see a lot of use of losartan. That is, if anybody just Googles it, they'll find out that it has a 2.5-hour half-life. And we have a vulnerable population of the obese person, African-American, older, with chronic kidney disease and diabetic. The odds of that person having non-dipping, nocturnal hypertension is about 100%.
Yes.
And we're using something with a 2.5-hour, and yeah, it has a metabolite that'll last for 6 hours. That's not enough. It's enough for when they come into the doctor to pretend to have their blood pressure controlled, but it's not 24-hour control. So I use a lot of telmisartan. It's a 24-hour half-life, and it gets rejected, and about 50%, and I don't know which 50%. And so I end up, you know, having to scramble afterwards. They say, oh, it was rejected, you've got to do something else. You know, and so olmesartan, irbesartan, azilsartan, and gorillasartan, any sartan other than losartan will have at least an 8-hour half-life. Wouldn't it be good if we actually give the clinicians that information right there at the spot?
Yeah, that's not a question, that's an assertion. I agree with you emphatically. I think absolutely. We should have that. That's something that I think would be really high yield to have immediately available to us at the time of prescription. We really embrace shared decision making. I've seen this with, for instance, apixaban, Eliquis, right? The guidelines, the AHA, ACC guidelines, which tell us about how to anticoagulate people. I did a lot of time with atrial fibrillation, and so that informed the 2 clinical trials as well, and adherence. It's right in the guideline, which is shared decision making in order to prescribe these therapies.
Right.
But what's not mentioned in those guidelines and in the updated guidelines from last year either is what people might pay this very issue as an obstacle. There's somebody who had their hands up, I think, online too. Okay,
Great, Tracy.
Thank you.
Anyone in the chat?
Nothing.
okay, great.
No, nothing.
Okay, thank you so much.
Well, fantastic.
Yeah.
Thank you.
Yeah. Thank you.
So.
Like the map that you showed